Hey guys, welcome to our annual protocol training review. For anybody who was not here during our January protocol training, we'll kind of get you up to speed on the review. So just to start out, the 2016 statewide protocols were officially rolled out. There were a few changes, not much to the EMT level. We're going to go through the protocols pretty quickly. We'll spend more in detail time as we go through the protocols for each individual emergency, respiratory, cardiac, OB. We'll spend more time as we get to it in our in-house training. I really do want to focus mostly on the cardiac arrest protocol that changed. That's pretty much the biggest, newest, and more challenging to get used to for our review. So we'll go through this. If you have any other questions, give me an email or call, we'll answer that. But for now, we're going to go through just the basic protocols really quickly. We'll spend some time on the cardiac stuff, and it won't be too long. You can refer back to the protocols on the iPads in each ambulance. On the iPads, there are copies of the new updated protocols. If you have any questions, refer to that. And as always, contact medical control if you have some question or issue. So, just the routine patient care as we always have done. Scene safety, making sure the scene is safe before we go in anywhere. Patient assessment, we approach the patient, introduce yourself, figuring out what the heck is going on. Medical versus trauma. Then we're going to move into our airway, our breathing, and our circulation. Transport decision, are we going to go lights and sirens, are we going to go with traffic? And also, most important, which hospital are we going to? If a patient chooses to go to Danbury, we should allow them to go to Danbury. If they want to go to New Milford, let them go to New Milford. It's up to ultimately the patient choice, but however, also, what is their issue that they called the ambulance for? For example, cardiac issue. If they're having a heart attack, we're not going to bring them to New Milford. If they're having let's say, a bad motor vehicle accident, or multi-system trauma, high mechanism, those are more things for a trauma center, which would be Danbury Hospital. And Milford Hospital does mostly routine stuff, routine BLS, not feeling well, common cold symptoms, banged up body part. They can do quick fixes. But for the more serious stuff, we're going to transport down to New Milford when appropriate. So just keep that in mind. If any questions, definitely contact the doctor at the hospital, medical control. Explain to them the situation that you're in, and he'll help you out to decide whether to bring them to Milford or go down to Danbury. This looks like on page 11 of the protocol. It gives might be kind of difficult with the video. Hopefully you can hear me. But it gives a breakdown of the different vital signs for patients, adult, child, infant, respiratory ranges, blood pressure ranges, oxygen level ranges. So keep that in mind if you have trouble figuring out or you can't remember what an infant blood pressure should be. You can recall back to the protocols on the iPad. We're going to fast forward through some of these things here. One cool thing is if you are in the protocol on the PDF, they have the built-in links. You can kind of see on the video, they're highlighted blue. If you were to click on that, it'll go straight to that protocol page within the document. So it's pretty cool. Abdominal pain, just not really much, nothing has changed really on the BLS level. One thing you have to keep in mind is what kind of abdominal pain is it? Is it an epigastric pain where it's more of a chest pain? In that case, you may want to refer to the 12-lead protocol review. So, should you obtain a protocol in an epigastric pain, well, it does fit the 12-lead guideline, which you would do a 12-lead for. Here, we're lucky enough to do the 12-lead program where BLS level can do it as long as a medic is either going to your location or has been attempted to be dispatched. Allergic reaction, nothing really changed there. Just make sure you differentiate between allergic reaction and anaphylactic reaction. For an allergic reaction, There may be some hives, but there should not be any respiratory or blood pressure changes. In a true anaphylactic reaction, you may have the hives, the swelling, redness, along with hypotension and difficulty breathing, the wheezing. In that case, that's where we're going to administer the EpiPen. EpiPen adult, 0.30, 0.3 milligrams IM. For pediatric, it's going to be half of that, 0.15 milligrams IM. For asthma, COPD, bronchitis, croup, all of those things, main priority is the patient's breathing, right? So you can administer or help the patient or assist in their meter dose inhaler, MDI, just basically their albuterol treatment. They can take a couple puffs of that every 5 minutes, reevaluate. That should hopefully help the patient. If the patient's not prescribed one, administer oxygen. That's the next best thing that we have. For our protocol, any oxygen saturation level 94% or greater, we want to hold off on oxygen unless they're having difficulty breathing. So, the patient is having an asthma attack, for example, with wheezing, difficulty breathing. Let's pretend their oxygen levels at 96% on room air. At that point, we can give oxygen because they're having the complaint of difficulty breathing. We're never withholding oxygen from a patient who can't breathe. But let's say our average patient who, for just not feeling well, oxygen level is 95% on room air, no trouble of difficulty breathing, no trouble breathing. We do not have to administer oxygen because our goal is 94% and it met or was greater than that goal. So just keep that in mind. Bill will most likely flag you if you give oxygen to a patient with 94% and you don't document why you did that. So keep that in mind. Behavioral emergencies, you have a couple options. You can use a cravats for restraints. We have our non-invasive padded cravats that you can use. Also, the officer, if you feel endangered, can ride in the back with you with the patient handcuffed, making sure if the patient is handcuffed, the officer should be in the back of the ambulance with you. Keep that in mind. They shouldn't be following. They should be in the back with you. In the event that something does happen to the patient, the officer will be available quickly to assist you. Childbirth, we're not going to really touch upon right now. We're going to get that more into detail during our childbirth in-house training. During our in-house training, similar to what we did last year, we're going to have our birthing mannequin. We'll do simulations on exactly how to deliver a baby. So keep that in mind. Hypoglycemia, low, hypoglycemia, low blood sugar. If a patient has low blood sugar, usually under 70, we are going to administer oral glucose. As long as the patient has an intact airway, the patient can basically breathe on their own, swallow on their own, they can function, they can talk. If they have an intact airway, pain airway, then we can give the glucose. If they do not have a functional pain airway, we are never going to give glucose. We do not want to put something in someone's mouth who cannot maintain their own airway. The last thing we want to do is give somebody with altered mental status who's drooling, can't swallow properly, something else in their mouth so they can choke, aspirate, and you have more work to do. So avoid that. Anyone who is alert and responsive and can talk with you, GCS of 15 with no altered mental status, intact airway, blood sugar under 70, we're going to give oral glucose. For additional administration of oral glucose, we'll allow 1 tube. After 1 tube, we should contact medical control. Hypothermia, severe hypothermia with colder weather. We want to warm the patient if they're in severe hypothermia where they may not have a pulse, so it's a cardiac arrest. You want to be very careful with these patients, move them very slowly. You don't want to damage tissues. When the tissues freeze, in severe hypothermic patients, you can have localized freezing, but also bodily wide freezing of the body, basically. So once once the temperature of the body gets down to a certain point, your metabolism slows, your body functions slow, and eventually your heart is going to slow. So you may not be able to feel somebody's heartbeat. Take a few extra seconds to evaluate that, so we can spend up to a minute evaluating for somebody's pulse and respirations, because they could be so slow due to the cold. So for these patients, if you find they're not breathing and do not have a pulse, we're going to start CPR, which we will go over the CPR guidelines. For these patients, you want to try to warm them, put blankets on them, turn the heat up in the ambulance. I know it might not be kind of uncomfortable for you, but for these patients that need the heat. Going back to our cardiac arrest patients who are hypothermic, move them slowly like we talked about. We're allowed to defibrillate them one time. After one time, we're just going to do straight CPR. So remember that, hypothermic, one time defibrillation, and the rest is going to be CPR. Nausea, vomiting patients. Let me try to zoom this in for you. Might help you read it. Nausea, vomit patients, basically what we can do is give them a barf bag. That's all we can do. And more care, again, we're going to talk about that when we get into that more specifics in our in-house training. I'm not going to spend that much time because nothing really changed. Same with OB. Pain management, we can't do anything really with pain management. Position of comfort. This is a pediatric that faces the Wong-Baker face scale. To the left is a no pain, which is a smiley face, and to the right, 10 pain, frown face that's crying. Alright, the next video I'm going to do after this protocol review is going to be our Narcan protocol review. So we'll do a quick, brief overview of the poisoning or substance abuse overdose. For known opiate overdoses or suspected opiate overdoses, we can give Narcan. We're going to give 1 milligram per nostril for a total of 2 milligrams. 1 milligram per nostril, total of 2 milligrams. For a patient who is suspected opiate overdose. So, these patients, what does that mean? Suspected opiate overdose. Some sort of opiate. Heroin has been going around. So, if they took heroin, they could have injected it, they could have snorted it. Whichever method they do, they take it. Their respiratory rate will probably be diminished, so they'll have a respiratory depression. Their pinpoint pupils, possibly. They may have a slower or fast heart rate, depending on if it's mixed with anything or not. So, for our protocol, we can't give Narcan to everybody, and we're not going to give Narcan to any old opiate overdose. They have to fit the guideline. The guideline for opiate overdose for Narcan administration is going to be if there is any kind of respiratory depression. So what I would say is anything under 10 respirations per minute, we're going to administer Narcan. So if you have a suspected overdose on heroin, they have pinpoint pupils and they're only breathing about 8 breaths a minute, and we can give Narcan. How are we going to do that? Well, 1 milligram per nostril in the atomizer. We're going to put that together and we're going to administer 1 milligram per nostril. If you have any other further questions on how to set up the Narcan device or how to use it, let me know, email me, and we'll catch up with that. Alright? But look for the next video of the Narcan training. It's coming up soon. For seizures, you want to try to figure out why is the patient having a seizure. Does the patient have a history of seizures? Do they have brain tumors? Are they hypoxic? Do they have low blood sugar? Anything could cause a seizure. So it's important to figure out, or try to figure out, what the heck is going on and why the seizure is happening. For these patients, just keep them comfortable. If there's any sort of furniture or something that they can hit their head on or hurt themselves, move it. Try not to move the patient or put your hands on the patient while they're seizing. You can try to give them oxygen, passive oxygen. After they're done seizing, make sure they are oxygenated. You may have to ventilate for a few minutes. Can be postictal, confused, and combative when they wake up, so keep that in mind. So for smoke inhalation, unfortunately our protocols do not allow us to use any CO metering devices like the Ratified that we have. We are no longer able to use that. So when we get called to the structure fire to evaluate somebody with possible smoke inhalation, we can no longer really do anything other than transport them to the hospital. We can give them some oxygen if we have to. We can try to use the pulse ox, but remember, smoke inhalation, that is going to be carbon monoxide, CO. CO binds to your hemoglobin in your blood with much more affinity times to the hemoglobin versus the regular oxygen. So keep in mind, you put the pulse ox on a patient who is potentially has smoke inhalation, you may have a perfect reading of 100%, but that 100% could be carbon monoxide or it could be oxygen. We have no way of telling because our protocol does not allow us to use any other devices. So when we get called for the structure fire standby, all we're doing is standing by. We cannot evaluate efficiently. All we should do is transport the patient to the hospital. Okay, for stroke. Stroke is a tricky one because strokes can mimic or things can mimic a stroke. What you want to do is always obtain a blood sugar. On stroke symptoms, facial droop, you have the arm drift, the speech problem. You want to obtain a blood sugar first because hypoglycemic patients can mimic stroke symptoms. So, get that blood sugar, medical control is going to want that blood sugar documentation. They are going to be looking for that blood sugar. Also, one very important thing that you want to figure out is the last time the patient was seen normal. That's going to be the number one question all the doctors are going to ask you. So, when the heck was the patient last seen normal? Was it yesterday when they woke up? Or was it last night, or just 10 minutes ago? So, very important. At the bottom here, I'm not sure if you can see it, but that's our pre-hospital Cincinnati stroke scale. The FAST. Facial droop. Does the patient have equal smilings, exactly equal on both sides? Can they smile? Arm drift. Have them basically put their arms out in front of you, put the palms up to the ceiling, close their eyes. If they have drooped to one side or the other, then that's a possible stroke. And also speech, ask the patient to say some sort of sentence. If they can say it normally, then it's fine. If not, there can be wrong words. There can be unable to speak, it can be garbled. Just keep in mind, when did it exactly start? Syncope. Syncope means passing out. A whole bunch of things can make a patient pass out. Blood sugar, you want to do a 12-lead BLS. Vital signs. Acute coronary syndrome, patients having chest pain, we can do our BLS 12-lead if no medic is available or has not been dispatched. We should be requesting one. But we can do it if the medic is not there yet. Also, what medication do we want to give? Always aspirin. As long as the patient's not allergic to aspirin, then we can give the patient aspirin. Alright? I'll zoom in here real quick. You guys can see that. That is the 12-lead placement. So, for anybody who missed the January's training, didn't get a chance to actually do the hands-on BLS 12-lead protocol placement of the stickers and leads, come see me if you're not comfortable with it. We also went over transmitting the protocol transmitting the EKGs to both EMS charts and uploading it, and also transmit it to Danbury Hospital or New Milford Hospital. Once you transmit it to New Milford, they're going to say, yep, come here, or no, go to Danbury. If you go to Danbury, make sure you transmit it again, just to make sure they have it for a second time, and tell them that you transmitted it. Hopefully you already have a medic with you. Okay, this is what I really want to get to. We're going to spend a little bit more time, and then we'll finish up. The cardiac arrest. This is very new to us. As a cardiac arrest protocol, it's new. So, for what we're doing, EMS arrived on scene. From the point EMS arrives on scene, we are waiting 8 minutes. We are first, let me rephrase that. EMS arrives on scene. We are initiating CPR, mechanical CPR. We're doing hands-on CPR first, initiating that, and then mechanical CPR with the Lucas. So, first thing we do, we arrive on scene, figure out, oh, it's a cardiac arrest. First thing we're doing, CPR. We're bumping on the chest with our hands. We're doing manual CPR. That's what we're doing. Manual CPR first. Manual CPR first for the first 8 minutes. We should not delay CPR to put the Lucas on. So, first thing we're doing, patient contact, figure out if they're in cardiac arrest. Figure out they are. Then we are doing manual CPR, then get the Lucas ready. That's the mechanical device, get the Lucas ready. But we should never delay CPR for getting the Lucas. Start CPR right away as quick as you can once you get to the first patient contact and you notice it is a cardiac arrest. So from there, for the first 8 minutes, we are doing CPR. Now, we have one option. We actually have two options. First option, for airway. You can put an OPA or an NPA in and use passive ventilation with a non-rebreather, or we can use a BVM. So, passive ventilation meaning first get on scene, one rescuer is doing CPR with manually. The second rescuer open up the airway, putting an OPA or NPA in, and slapping on a non-rebreather at 15 liters. Second option would be the same thing with the CPR, starting CPR, first patient contact, putting that OPA or NPA in, and the only difference is ventilating with a BVM. Now, if you choose the method 2, ventilating with a BVM, we are changing up the compression to ventilation ratio. If you choose a BVM, we're doing 1 BVM breath for every 10 chest compressions. On the 10th chest compression, do a breath, and then do the next compression. We shouldn't be delaying or stopping CPR to do that breath. As you come up off the chest, when you're doing the up motion in the CPR, do the breath quick and then go down. So we shouldn't be 1, 2, 3, 4, 5 up to 10, stop, and then do breath and then go. It should be all the way up to 10. As you're coming up, do the breath, go down, 11, and keep going. So what I would recommend, if it's a 2-man crew, start manual CPR, put the OPA or NPA in, slap a non-rebreather on with high flow oxygen, get the Lucas ready, do that stuff, and go from there. That would be my recommendation, especially if you only have 2 people on a crew with no other assistance. What you can also do is tone out for extra manpower if you're having trouble, need extra lifting assistance, but if you have a 2-man crew, if you prefer, I would prefer to do the passive ventilation. Throw the OPA in, NPA, with a non-rebreather with oxygen, and just do continuous CPR. Just looking at my notes here to make sure I hit everything on that. do try to enforce is this team-focused CPR, team dynamics. Obviously, if you have more than 2 people, sometimes it's kind of difficult, but do the best you can with it, because you're probably very rarely going to have 6 people unless you call for additional resources. So, that cardiac arrest, if you guys have any other additional questions, please let me know. Main thing you have to know is, upon a first patient contact, realize it's a cardiac arrest, get right onto CPR. Do not delay anything. Do first manual chest compressions, work your way up to the mechanical device. For the first 8 minutes is going to be straight CPR with the option of either passive oxygen with an on breather or ventilating with a BVM. If you choose BVM, you're going to ventilate 1 breath every 10 compressions. One thing I also forgot to mention is that first 8 minutes, go back up to it here, and you guys can kind of see that right here. So, first 8 minutes does not count if a bystander is doing CPR. So, give you the example. If the patient's family member starts CPR, you get on scene, that first 8 minutes starts when you, the provider, start CPR, not when the bystander starts CPR. Now, if a first responder gets on scene, the fire department gets on scene, somebody medically trained gets on scene from, let's say, the police department or the ambulance or fire departments, they get on scene before us as a first responder and they initiate CPR. The 8 minutes starts when they initiate CPR because they are a provider over us. So, 8 minutes starts when the first healthcare provider related to us, the Milford ambulance, starts the CPR, not when dispatch is giving the bystander or family member instructions. Okay, so keep that in mind. Just one thing with CHF. CHF, you have the, what kind of breath sounds? You have the rails or crackles, right? That's that fluid, that pulmonary edema in the lungs, if it's depending on which side of the heart. For these patients, if they do have pulmonary edema, they have CHF, sit them upright. That may help them a lot, especially if they're laying down. A lot of nursing homes we go to, patients laying flat and they can't breathe. Well, I wonder why. Sit them upright and hopefully that'll help a little bit. Give them oxygen if you have to. We can't use CPAP for BLS, so that's not the option there. But what you can do is assist the medic if they ask you to help set it up. So you guys should be familiar with what it looks like. Burns, don't forget the rule of 9s here. We're going to go over that during our burn chapters. We also have an online training for that as well once we get up to it. Spinal injuries, we're going to skip that for now because I'm going to do a separate video on SMR, our Spinal Motion Restriction Guidelines. So, CPAP, we're skipping that. These are just mostly ALS procedures. Trying to get down to the medications here. If you have trouble, refer back to this for the EKG placement. For our March training, we're going to be going over medical legal, so we're going to talk about DNRs and stuff. Just a quick thing on LVADs. LVADs, kind of tricky. Basically, it's left ventricular assistance device here. It's basically a unit that is controlling the blood flow in the patient. So, you take a blood pressure on these patients, you may not feel a blood pressure, you may not feel a pulse. Alright, looks like maybe the medications are all the way at the end. But for our medications that we can give aspirin, Aspirin, we can give 4 baby aspirins for a total of 324 milligrams. Each baby aspirin is 81 milligrams each. So, for example, if a patient took 2 baby aspirin before we got there, we can give 2 more to total for 4, for a total of 324. We can give oral glucose. Our oral glucose is 15 grams per tube. We can give one of those before we contact medical control. We can give an EpiPen. Adult EpiPen is 0.3 milligrams IM, and pediatrics or child is 0.15 milligrams IM after that. So, oxygen, obviously, we can give oxygen for a SAT under 94%. Our goal is 94%. What else can we give? We can assist with nitro sublingual under the tongue, 1 spray or a tablet. Sublingual under the tongue, making sure that the patient's blood pressure is above 100 systolic. And these are all the medication reviews. A lot of them are just ALS. And we can also give Narcan, like we talked about, 1 milligram per nostril for a total of 2 milligrams. And the patient has to be in respiratory depression, under 10 respirations per minute. So that will conclude our overall statewide protocol review training for today. If you guys have any other further questions, feel free to email me at any point. I will get back to you. And keep an eye out for additional videos. I'm going to be working on the backboarding protocol video, the Narcan video, and a few other, the 12-lead video. So keep an eye out for at least 3 more videos from me, and that will be all our January protocol review. So again, if you have any questions, definitely feel free to contact me, and I will get back to you. But for now, if you have any questions, also refer to the protocol kept on all 3 iPads in each ambulance. There's also a copy at headquarters if you run into any trouble. You can also find the protocols online under the Department of Public Health website. So, lots of resources. Reach out to me if you have any trouble. All right? I'll see you guys soon.